Hello and welcome to What End is Up when it comes to hormone replacement therapy. I am very delighted that you are here. Before we launch into everything, I think it's necessary to have an understanding of just a few things. And the first being that while I acknowledge that estrogen and progesterone are not the only two sex hormones that we have. That's the focus of this particular webinar, just because that is what is usually prescribed or most commonly prescribed when it comes to hormone replacement. Secondly, I want to make it very clear that you all understand that there's no right or wrong way when it comes to your decision about HRT. It's a very personal thing. And what really matters is that you know the risks and the benefits of taking hormone replacement or not taking it. And also what matters is that you have a two-way discussion with your healthcare practitioner so that you can understand the ins and outs of everything. And just having your doctor say that they're not comfortable prescribing hormone therapy in general or to you specifically is not a discussion. That's just their opinion. So every woman has the right to be informed. And this is one of the reasons why I'm here. So having said that you should be able to have a discussion, what's interesting is that you may come away from this webinar knowing more than your general practitioner or OBGYN or even endocrinologist when it comes to menopause and hormones. And that may be a bit startling to some of you. It won't be startling because you've already had that experience firsthand, unfortunately. So what we need to understand is that when it comes to the subject of menopause and hormone replacement, it really hasn't been taught in medical school. And especially since the 2002 WHI Women's Health Initiative study. So if it's not being taught in medical school, and unless doctors really make a concerted effort to go out and become educated around this, they're really not going to know what end is up. And there's so much confusing literature and talk surrounding around hormones that it is hard to know what end is up. So that gives us kind of a better understanding why there's only 4% of women who are menopausal, postmenopausal, who are on HRT, whereas before the Women's Health Initiative study, there was 23%. It also gives way to an understanding of why more and more women are going to online companies who are offering hormone replacement therapy online, very easily to get. And because they're not getting the help that they want. And even though I am not crazy about getting hormones that way, because I don't think the whole woman is being addressed, her health in general, again, I understand it, and it is becoming very big business. So I'm hoping that will change. So my goal today is to give you as much information as I can in what a fashion that I feel is good and responsible. And do I have biases when it comes to HRT? Yes, I do. I think probably every practitioner does. And you will probably be able to spot out one or two of those as we go along. So if you're new to my channel, or if you're new to me on this webinar, you probably like to know a little bit about me, what qualifies me to be in this space. Well, the first thing is I'm a functional medicine practitioner and nutritionist. I've been in practice for about 18 years and helping people, both men and women, in the arena of chronic diseases. So I look very carefully and help with digestion, hormones, thyroid, weight gain, diabetes, looking very closely at blood work, looking very closely at history and what's going on in the person standing right in front of me. I received my BS in dietetics and food administration many moons ago. I found functional medicine about 20 years ago when I was going through my own healthcare crisis. And actually it was when functional medicine was still fairly new. So I feel like I was fortunate to have found it. I was in a space where I was kind of a mess. My digestive system was a mess. My adrenals were pretty shot. And I had actually thrown myself into an early menopause at the young age of 43. So I was searching. And what ended up happening then is I realized that I could end up helping a lot of others who were in the same situation as I was and who had other things going on as well. The perimenopausal and menopausal part of my practice has only really been in place for about 2 years. And that came out of basically two different things. One was that I was watching my clients who had been with me for a number of years moving into menopause and losing ground. So I knew their diet, I knew their lifestyle, their exercise, their supplements, basically everything about them. And if you were to look at all of that on paper, they were looking pretty good, but yes, they're still losing ground. So I knew I was missing a very important part in supporting my women. So that was one thing. The other thing is that I'm 66 and I was looking at my contemporaries and seeing the difference between a lot of them and me as far as our energy, aches and pains, how we felt, just the shape of our bodies, all of that, and general health as well. And I going, there's something wrong here. And I've been on hormone replacement for about 16 years, and I think it has made a huge difference. So both of those reasons um, really threw me into, I was on a mission to find out as much as I possibly can so then I could be an advocate for my clients and I could be an advocate for other women that happen to find me or hop onto my channel. So before I jump into our topic today, I would like to make it very clear that I am not a doctor. And nothing I say here replaces the care of your healthcare professional. And this webinar is for informational purposes only. Okay, so this is what we'll be covering today. We'll be talking really briefly about perimenopause and menopause, just so there's definitions and understanding there are surrounding those. The benefits of estrogen and progesterone, bioidentical versus synthetic, delivery forms of estrogen and progesterone. Do we test? Do we not test? When to start and when to stop HRT? What is beyond HRT? Is there anything else that's important? And yes, there is. And then I'd like to give you some takeaways and some recommended sources so that you can continue to educate yourselves after we're done here. So with that, let's move into perimenopause. So perimenopause is the precursor to menopause, and many women will feel that they are on a roller coaster during this time, and for reasons. Your ovaries are starting to shut down and they're scrambling to write things and to find a rhythm again. They're kind of all over the place. Now, some women have very little to no symptoms as they move through perimenopause, and lucky them. But I would say that most do, and it's often not a nice ride. So let's look at what happens first. Perimenopause is the 2 to 12 years before menopause hits, which menopause occurs on average around the age of 51. So again, perimenopause can be somewhere between 40 and 51. It can cause heavy periods, skipped periods, mood swings, insomnia, night sweats, brain fog, hot flashes, just a nice myriad of symptoms. And what happens first is that progesterone usually drops first, which is why anxiety and insomnia is such a big occurrence. So progesterone has an action on our GABA neurotransmitters, and our GABA neurotransmitters are very, very calming. So after the progesterone drops, we will often see a drop in estrogen. And even though there's a drop in estrogen, maybe overall, we'll still see spikes and dips in where our estrogen levels are overall. And that's when we can really feel that roller coaster ride. One of the things that I really like to pay attention to during this time is a woman's adrenal health and condition of her adrenals and support those. And then also looking very closely at her thyroid. So I do a complete thyroid panel. I recommend that for all of my clients, which is not just TSH and free T4. It's also including free T3 and the antibodies, and if we can, getting reverse T3. One of the reasons that I do like to really look at the health of the adrenals is that all four of our sex hormones are made in the adrenal gland. So that includes estrogen, progesterone, and DHEA. So we can kind of bolster things up if we can make sure they're in good health. And then we move into menopause. And in a sense, it's kind of an imaginary line that's been kind of made up, but it's defined as not having a period for a year. And many women, when they reach about this time, they'll find that the roller coaster that they've been on had settled in, and it's settled down. And you were no longer having those estrogen spikes all over the place. We are no longer making estrogen from our ovaries. We may still make a little bit of estradiol in our breast tissue and our brains from cholesterol, but our ovaries have ceased to make it. So the hot flashes and night sweats and insomnia and maybe some of the lashing out, or you're just kind of like, oh my gosh, overreacting to things. Incontinence and anxiety may not be hanging around anymore. So often a woman will go, oh, I got through that and I'm good to go. But the thing is that that's just the stuff that's showing above the surface. That's the tip of the iceberg. Actually, the more important things are below the surface, are the things that you may not know that are brewing inside of you beneath the surface here from here on out. And that is disintegration for a lot of women, bone health, so osteoporosis, cardiovascular disease, the onset of that. And by the way, more women in menopause die from cardiovascular disease than men, or at least caught up with them, and more women die from cardiovascular disease than they do from cancer. And that's a really important point to make because most women are afraid of hormone replacement therapy because of cancer. So osteoporosis and cardiovascular disease are really more prevalent and dying from those two than cancer. And then we have diabetes, and diabetes is a form, well, it will cause inflammation, and we know that inflammation is the driver of all chronic diseases, all the diseases that we go into our healthcare provider for, and it is the underlying cause of inflammaging. So it definitely will accelerate our own aging. Estrogen has an effect on every single organ and system and tissue in our body. So it only makes sense that when we lose our estrogen, that our ligaments and our joints will have problems because it affects our mitochondria, and then it will also affect our gut. We can see gut issues really coming along here. So it's unfortunate two things. One, that our doctors will not offer it. You know, most of my clients have to ask for it. And number two is that, in other words, there's no discussion led by their doctors. And number two, women often will not ask for it. And my experience has been in my clinic that unless a woman has been on HRT, that once she's about 5 years into menopause, we will start seeing at least one or two of these symptoms that are happening underneath the surface here. So we are not immune. So let's look more closely at the benefits of estrogen and then of progesterone. So it increases energy, and I already threw out mitochondria. And mitochondria is little powerhouse cells or the little powerhouses in our cells. So it gives us energy. It improves sleep, maybe not as much as progesterone, but it does. It will prevent osteoporosis or slow down the process of it. It will reduce heart attacks and strokes. It is neuroprotective, so it will help with dementia and Alzheimer's. It does increase sexual desire, and that's important for a lot of women who still want to maintain their intimacy with their partner. It keeps the urinary tract healthy, reduces incontinence, which is really nice. Regulates weight, which is, I think most women find that keeping their weight down and regulating their weight becomes more and more difficult once they hit perimenopause into menopause. It regulates appetite. That's part of this, right? It modulates mood, so it can really help with the serotonin receptors. So that would be more on the side of depression. Increases insulin sensitivity, which plays a role in diabetes and inflammation. It keeps inflammation in check because it is anti-inflammatory, the right kinds of estrogen are, and it affects your digestive function. It can prevent gallbladder issues, which also plays a role in digestive function. And then it reduces breast and ovarian cancer, which may be a real surprise to some of you to see this up there, but more and more studies, even if they're just observational, are pointing to that. Okay, the benefits of progesterone. Progesterone prevents the thickening of the uterine lining, so it is a must if you do have a uterus and you are taking estrogen. It also calms. It also improves sleep. It prevents osteoporosis, not as heavily as estrogen, but it does. It lessens anxiety. It can help with muscle building, and it's also neuroprotective. So again, the dementia and Alzheimer's portion of it. So there are many practitioners or doctors out there who will not give or will not prescribe, let's put it that way, progesterone to their patients who do not have a uterus when they are giving them estrogen. But if you look at all of the benefits that progesterone also gives a woman, I highly encourage and recommend that a woman asks their doctor for a progesterone as well. So bioidentical versus synthetic. I am going to guess that most women think that compounded hormones are the only bioidentical form of hormone available. And that's not true. Bioidentical hormones are also available in an oral form, patch, gels, pellets, injections, and suppository forms. Yay! So let's talk about the difference. Definition of something that's bioidentical. It means that something is made with the exact same molecular or chemical structure as you would find in nature. Okay, it's pretty simple across the board, not just hormones. Synthetic, it is a compound that mimics what is found in nature, but something has been slightly changed. And they are what we call analogs. And many times these analogs can take something that was made in nature, and because that slight little change has been made, maybe they've just added another bond or something like that, it will react differently and cause a different effect inside of our bodies. So it can have a big impact. And actually, this is how drug companies can patent and market medications. So a lot of our medications, and of course our hormones here, they come from a natural source or naturally occurring, but they can't patent those and they can't sell them as a pharmaceutical. So that's why they do that. By the way, all of our hormones, even our compounded hormones, are made in a laboratory. So they are synthesized, made in the laboratory. It's just whether or not they are going to be identical to what we find in nature or something is added to it. Probably the most common synthetic hormones on the market And unfortunately, in my opinion, they're still on the market, which I kind of don't understand because there's so many other choices that are so much better for women because they are bioidentical. But what's left are actually the hormones that were also used in the WHI study, the Women's Health Initiative study. And you've heard me throw that out there, that study out at least 3 or 4 times already. And if you're not familiar with that study, I do have a video up on YouTube talking about that. And I think it's really important that a woman does familiarize herself with that study because there are so many references made to that. And in order to have an understanding of the environment that we are in right now when it comes to hormones and there's so much confusing information, so much of that and the culture comes from that study. So going back to the most common synthetic hormones on the markets, that would be Premarin, which is an estrogen-only hormone, and that's made from a mare's urine. It's conjugated equine estrogen, so it's from urine, so they are the metabolites. And again, they're synthetic. And then we have Provera, which is a type of progesterone, but actually it's a progestin, which is very different. It is synthetic. And then we have Prempro, which is actually the combination of both the estrogen, the synthetic estrogen, and progesterone. The FDA approved hormones, so those are the ones that are very standardized, which includes patches, gels, creams, and oral, and are all not all. Many of them are bioidentical, as I've already said. But the delivery method is what separates them from the compounding creams, not the hormones themselves. So what I'm trying to say here is that even though they're bioidentical, so the molecular the same as in nature, the drug companies have been able to patent them because of the delivery method. So it would be either in the patch, so there's the glue in the patch, okay, that's the delivery method. The gel, same thing. And orally as well. So, the FDA does not approve does not approve the compounded creams. And I know a lot of doctors want to stay away from those creams as a result. And the compounded creams, this is my opinion, even though they are not monitored or approved by the FDA, they are monitored very heavily by the compounding pharmacies and their umbrella, the companies or the association that they answer to. So I don't have a problem that they are very carefully and well managed. You might have a little bit of difference from pharmacy to pharmacy and how you might absorb creams based on the suspension that they're in from pharmacy to pharmacy. But you can have that as well. Let's say in a patch, there's different brands that use slightly different types of glue, okay? And that can make a difference in how a woman actually absorbs that estrogen. So even though compounded pharmacies are not approved by FDA, which also means that insurance companies will not cover compounded creams, I think they are very safe. So I'm just gonna, I made a reference to how an analog can act very differently in our bodies. And I'm just going to take the sample here because it's very applicable to what we're talking about here. The difference between the bioidentical progesterone that our bodies make, we only make one type of progesterone, and the analog, which is progestin. Okay, these are all the wonderful things that progesterone will do for us. Okay, improves cardiovascular health, may reduce risk of cancer, good for mood and sleep and mental health, brain health. And then look what progestins do. And by the way, progestins are found in birth control pills. They're found in the IUDs, the Mirena ring. And they're found in other places too, but those are the main places. So these can cause high blood pressure. These can increase the risk of breast cancer. These can also cause anxiety and depression. So almost the same word in the same name, but they act very, very differently. And again, I want to point out that progestins were the type of progesterone that were used in the WHI study, which again has set the whole stage of what we run into in the last 22 years, and we continue to run into. So I'm going to talk about the delivery methods of estrogens, and you're going to see a little bit of my bias here. So we have oral, we have transdermal, we have pellets, we have vaginal, and we have injections. So oral, you see I put here, it's not my favorite. And again, I want to say that each woman is different. It's between her and her practitioner to determine what works best for her. And sometimes it's not a slam dunk. Sometimes it takes a few months, even maybe a year or two, to figure out what works best for a woman. Okay. So oral, why is it maybe not my favorite? I'm not opposed to it, but the reason why it's not my favorite is that it has to pass through the liver and also go through our digestive tract. So there's a little more room for inflammation to go on here. And I just think there's other ways to go about that. Why would a woman choose to do oral? It might be because she just was not absorbing the transdermal enough to get her levels to where she wanted them to be. And maybe she tried pellets or didn't try pellets and just decided, no, not doing that. And, you know, the vaginal is non-systemic, which I'll talk about more. Injections, I think, are just, you know, coming onto the market, or at least I'm being made aware of it just recently. So that's why a woman might choose an oral form. Transdermal is my favorite, and I think it's used by most practitioners. So we can get transdermal in the form of a patch, a gel, a cream. That's pretty much it. And by the way, going back to oral, it can be a troche, which is something you kind of suck on, or can be a pill. So transdermals are easy to do. And again, I think that's what most practitioners do choose. Pellets is my least favorite, and that comes from a couple different reasons. One is I've had some of my clients come in and just be going every which way. And the thing is with pellets is that they're injected into your gluteus max, and they're there for 3 to 4 months. And you do get the most amount of the estrogen and testosterone in the very beginning, okay, when it's first injected, and then it dissipates and gets lower throughout the 3 or 4 month period. Now, some women love this because it's just like a steroid high in the beginning. And they do okay on it. But some women will get the high, and then towards the last 4 weeks or so of their cycle here, cycling on the pellets, they kind of run out of the hormones and they're not feeling so great. The other problem is that once those pellets go in, they don't come back out. So if they are too high of a dose for a woman, and unfortunately that happens all too often, she is stuck with it. I've had some women just be so uncomfortable for a couple months. The other thing is pellets are kind of big money makers, especially for the anti-aging practitioners. So they go for maybe a weekend training on how to do pellets, and all of a sudden they're handing them out like candy, and they're not really addressing the person that's in front of them. So while I know there are some very good and responsible practitioners out there that do use pellets, I would say the majority of practitioners that do use them are not that responsible in what I've run into. Okay, vaginal. Vaginal is non-systemic. And what does that mean is that the hormone that is going into the vaginal area does not go into your bloodstream. So it will not raise estradiol throughout your system. So it's a very safe form of HRT for any woman who is worried about cancer, who's had cancer in the past or has cancer in their family. So what vaginal estrogen will do is it will help with the vaginal tissue stay pliable and stay moist so you don't have the dryness. It will help with the whole pelvic floor a little bit. It will help keep the urethra and the bladder and the kidneys healthier. It is, if a woman is having repeated UTIs, for me, it's a must to have that. Estrogen not only changes the physical ness of the tissue and how it works, it also changes the pH in that area. So when we don't have estrogen on board, it can cause a pH that makes the bacteria that causes UTIs to proliferate. All right, injections. And again, I think I mentioned that injections are kind of new on my radar and not as common. And you do it at home, and apparently it's usually 2 injections per week. And a lot of women choose this for the same reasons that a woman may choose the oral route, in that the transdermal didn't work for them. Some women are also afraid of transferring estrogen to their partners or their animals or pets, their children, their grandchildren. So these are, different ways of getting estrogen replacement. And, again, it's a choice. And it's nice to find a doctor who is familiar with a couple different ones. All right, the delivery methods of progesterone and progestins. Okay, oral is, I think, a favorite amongst practitioners and probably the most common. And that would be, micronized progesterone. It's usually known as Prometrium, is bioidentical, and that's an easy form. And often it is favored over any type of transdermal for a couple of reasons. One, most transdermals are compounded creams or creams over the counter, but a lot of women and doctors have found that oral progesterone can help more with sleep and anxiety. Not, I haven't found that across the board, but that is out there. Transdermal is a favorite of mine. There are some women that are very sensitive to progesterone. They may feel depressed. They may feel very, very sensitive, teary-eyed. And transdermal kind of gives us the option of playing with the doses a little bit more and seeing what works for a woman. And for some women, and I'm included in this group, oral progesterone, for whatever reason, really bothers my digestive tract. It makes me very bloated. And my digestive tract is my weakest part of my body. And so I find that some of my clients also experience that. So that's another reason why maybe transdermal might be the way to go. And then we have the IUD and the ring, and that would probably be my least favorite, mainly because it's a progestin, but it will protect your uterine lining, and that's one of the things you really need to look out for if you have a uterus. So it does stay a little bit more local. It will do that. And again, some women who are very sensitive to progesterone, they prefer that. And then we have a vaginal cream and gel, and I think there's a couple different brands that are approved by FDA. So again, FDA approved often means that insurance will cover it, which is nice for the pocketbook. And it is very effective, again, to prevent the growth of uterine lining. How much it helps with sleep is to be a little bit debatable here. All right, we're at dosing, and I'm not going to talk about the specific dose of different types of delivery forms. What I'm going to be talking about is the different um, types of dosing that doctors will choose um, to put you on. And I want you to know about your options too, because often you're not given an option. So the most common is the static dosing, and that's where you receive the same amount of estrogen and progesterone day in and day out. It does not change, and you don't stop either one of them. And again, it's the most common, it's probably the easiest, it's one and done. You don't have to think about it. The second most prescribed would be your static dosing of estrogen, but then there is dosing of progesterone only. Sometimes it's 14 to 21 days out of the 28 days. And the idea behind that is that our bodies don't produce progesterone the whole time when we're cycling, when we're in our fertile years. And the idea behind that is to kind of mimic that cycle a little bit more. And progesterone does blunt the receptor sites of estrogen. That's part of how it works. So if you take that away, then the estrogen replacement becomes more effective overall. So that's the idea behind that. Now, if you do take the progesterone away and the estrogen is high enough, you will have a bleed. Okay, usually it's fairly light. It might only last for 2, maybe 5 days. So it should be very different from the period bleed that you experience during your fertile years. So you will have that. And a lot of women do not want to go back to having that. So again, it's a choice. The third option is a type of physiological dosing. And this is a method where you do need to use creams because you are dosing from day to day, mimicking your cycle when you were ovulating, when you were fertile. So what that means is you're going to be upping your estrogen as you move from day one of what a cycle would be, beginning of your cycle, to ovulation, and then you start bringing that estrogen back down, and then just the opposite with the progesterone, right? Progesterone's low at the beginning of the cycle, and it will stay low until after that 14th day. So what I'm trying to say is that your dosing of estrogen and progesterone will be varied during a 28-day imaginary cycle or time frame, and you will be dosing it, so it will change from every 2 to 3 days. It's much more complicated. I don't know that many practitioners that do that. I do know a couple women who are on it, and they absolutely love it. I personally did try it when I changed my dose or the type of hormone replacement that I was doing. I wanted to see what it was like. And it didn't end up being something that I liked. So it wasn't for me, but I tried it. And I'm really glad that I did. Okay, when to start and stop HRT? I think it is, and I already alluded to this, it's very important to possibly start it in perimenopause, depending on what a woman is going through. But especially if she's having a difficult time with her moods and sleeping, right? So maybe even just starting her on that progesterone is all she needs up until menopause, or maybe she needs a little bit of that estrogen as well. Now, a lot of doctors are not educated on how to do that or when to do that. So you may have to search a little bit to find a practitioner, or we can ask, okay? I have a lot of my clients asking for things, and sometimes we get it, which is really nice. Okay, so that is when I would recommend starting. And then when we hit menopause, obviously, I do have the bias. I do think it's important, even if a woman is no longer suffering from hot flashes and mood swings and things like that, for all of the reasons that we talked about, of all the things that estrogen does and progesterone does to help a woman as she moves through her menopausal years, which is about 1/3 of our lives. So, I just think, why not support our bodies the best way that we can as we move through those years? And what if, okay, so let me go back to, a lot of doctors will still dose to give you a very small amount of hormones and for the least amount of time. And again, this comes back from the WHI study. That's kind of the thinking, the mindset that's still around quite a bit. And so a woman may only be on hormones for 10 years. Now, NAMS, which is an organization that I would say most practitioners who are in the realm of hormone replacement do look to for guidance. And they've just recently, well, 2 years ago, the 2022, their statement that they put out. NAMS is North American Menopause Society. Their last statement hedged very carefully towards stating that, it's probably okay to keep a woman on hormone replacement. They hedged it and couched it as if she shows the need for it. Well, that's pretty arbitrary, I think. So it really did open the door, and I'm hoping that more women and more doctors will continue to keep their women on hormone replacement, because things don't go away if we go off of them. Now, let's say that you missed the window, that 10-year window that's still kind of out there of being put on hormone replacement, which a lot of women did if they had come into menopause in the last 20 years or so. So a lot of women who are 65 and older did not have the opportunity to go on hormones. So are they stuck here? No, they aren't. You can still go on hormones. It's just much harder to find a doctor who will place you on one. I do want to say here, really important, this is where oral estrogen, I would say, is an absolute no here, because it is more inflammatory. It is an analog. It is not bioidentical, and I think it increases the risk of heart disease. So I would say either the patch or the injections, anything but oral. Okay. All right. So do women, if they have missed that 10-year period and maybe they have built up some plaque, okay, maybe they've lost some bones, can they still benefit? And the answer is yes. And I would liken it to, let's say, saving for retirement. It's best to start saving in your 30s. 40s is still good. 50s, maybe not as good, but it's still better than nothing. Same thing with hormone replacement in the later years. Maybe we cannot reverse what plaque has been laid down, but what we can do is lower inflammation. We can make a woman more insulin sensitive. We can help her lose weight. We can lower that inflammation. And all of those things are the underlying causes of cardiovascular disease. Okay. So it still can be helpful. Can we reverse the bone loss that she has experienced in these last 10, 15, maybe even 20 years? The answer is no. Maybe we can replenish a little bit, but more than likely, we're not going to recalcify and remineralize her bones. But what we can do is prevent further demineralization of her bones and further progression of osteoporosis. So, and the other thing we can do is make her vaginal area and her uterus, all of those female parts, feel better to her. And I have an 83-year-old client, and she's a kick in the pants. And she had been given vaginal estrogen because she has had repeated UTI. So I am really happy the doctor did that. Now she resisted it because it was messy. I get it, but I told her she had to do it. And I also recommended that she ask her doctor for a low dose patch. I just thought, let's give her something. And her doctor was willing to do it. And I was really, really happy to see that. And she is feeling, she goes, oh my goodness. She goes, I have more energy. And she says, I'm actually flowering down there. And she says, I'm feeling things I haven't felt in many, many years. And so, yes, she's a kick in the pants, but it's benefiting her. And again, when to stop HRT? I would say never, because the benefits continue to be there. Right. Like I said, I'm 66. I have absolutely no intention of stopping my hormone replacement therapy. Okay. To test or not to test. So just as different types, different dosages, how long, when to start, all of these are up for grabs still. It just seems like in the realm of hormones, I would say it's not really up for grabs if you really do your research, but amongst practitioners, there's just so much conflicting information, and in the media, it's hard for us to figure it out. This is one area that also has so much controversy around it, to test or not to test. Now, you can test with either serum or blood, saliva, or urine. Those are three methods of testing. And I am going to be in agreement when a practitioner has given her client the lowest dose of estrogen and progesterone. Is there going to be a need to test? No, there's not, because that woman is not going to be getting enough hormones to even raise her serum levels. It's going to stay pretty close to the menopausal range. So I'm in agreement. If you're on low dosages, there's really no reason to test. If all you're trying to do is get rid of the vasomotor symptoms, all those little symptoms that are above the surface of the water here, the tip of the iceberg. But if you're doing something more than that, and you are trying to get serum levels up to a level where studies have shown that it is effective in reducing the risk of cardiovascular disease and preventing osteoporosis, that's where we want to see serum or blood to be a minimum of 50 picograms per milliliter up to maybe 150. So minimum of 50, maybe up to 150 is where we want to see that blood level. So that would be one reason to test. Let's talk about saliva for just a second. It's not recommended that you use saliva when you are using hormone replacement therapy, especially if it is transdermal, because it does not translate. For some reason, the levels are overstated and overexpressed in salivary. So they've taken, a woman, they've done serum, they've done salivary, they've looked at the two, and the salivary is overly stated. And they're also looking at the symptoms of the woman and how much they're giving to her. So saliva can be fine prior to hormone replacement therapy, prior to HRT. So really, that's only when a woman is still ovulating. Okay, that can be effective to see her levels, also to kind of see what her rhythm is maybe throughout the month. Before I go into urine, I want to go back to testing and not testing and where we are in our life cycle. So when a woman is in perimenopause, there are some doctors, and my clients have these doctors, who will test their estrogen levels to determine whether or not they are willing to put their clients, their patients, onto estrogen while they're still in perimenopause, while they're still ovulating and cycling. And it's interesting because, I already talked about how estrogen is all over the place during this time, from day to day, and then even throughout the day. So from what I've seen in my clinic and what I have studied and read, and my conclusion, what I've come to is that, I would treat the person in front of me more than look at the levels in the blood, because they're not going to really give you an accurate picture of someone in perimenopause. Now, what about the woman who's in menopause but is not taking any HRT? I have women all the time, and they're delightful and they're darling. Come in and said, okay, I'm ready to do HRT, and I'll ask my doctor to test my hormone levels. And I go, there's no reason to test your hormone levels, because they're going to be very, very low. They're going to be normal for menopause, but they're not, there's no point, because they're going to be low. Your body's not making them. So if you're in menopause and you're not on any type of HRT, don't bother. Okay. All right. Now we're going to get to urine, and urine's, I think, very important. And urine is also an accurate way of getting levels, what a woman's estrogen and progesterone levels are in her body. And you can do this at any time, basically, in her life, while she's still ovulating, when she's in menopause, and even perimenopause too, because, well, perimenopause, not so much, but during the fertile years and in menopause. And it is a test, because it is urine, it's looking at the metabolites. So one of the useful tools, the biggest useful tool of this, would be for a woman who is concerned about cancer in her family, or her. It is a way of looking at what your body does with estrogen. And there's different pathways that our bodies will take the estrogen down, and there are more inflammatory, and maybe a little bit more, because it is inflammatory, a little bit more on the cancerous side of things, that some women will have over other women, and some of it's genetic. I know a lot of people, a lot of doctors will look at the BRCA gene, and these are only certain, markers, genetic markers. There's many, many more that we can look at, but those are the most common. But when we're looking at urine, that can also give us an inkling of what's happening. And some people genetically will send it down more of that inflammatory pathway. And the nice thing about genes are we can turn them on and off. And so there are some adjustments we can do to the diet, and even supplementation, that can take that estrogen down a different pathway. So urine, there's two different companies that do it. It's more of a functional type testing. You can, the one that I'm familiar with is a Dutch test, and that is around $400. So that test specifically is one that I would recommend for women if they're concerned about cancer. Even if you're not, I would say to do that at least once, just to kind of see what your body does with estrogen. Okay, the last thing I want to talk about as far as testing is getting an transvaginal ultrasound. Now, again, if you are getting really low amounts of hormone replacement, then this wouldn't apply to you. But if you're taking more to the mid and high range that's out there, you might want to do this after you have been taking hormones for a little bit and things have settled down, just to make sure that the uterine lining is not thickening. I'd like to see if there's that balance. Okay. HRT is not the end all be all, and I just want to put that out there, even though you can tell I'm a big proponent of hormone replacement therapy. And it may feel like a magic wand to a lot of people, and it will help our bodies to stay young, but it is kind of like icing on the cake. We can't ignore everything that I've listed here, and it's not a substitute at all. So we have to make sure that our nutrition is good, right? And no one size fits all in hormones or nutrition either. And same thing with everything here. Lifestyle, so this encompasses sleep and body movement, stress reduction, and our mindsets as well. And our gut, your gut is the seat of your immune system. That has to be working very well. And it's also a gateway removing toxins and hormones. And then as far as environment is concerned, we need to make sure that we are, doing what we can to keep as many toxic substances out of our household, out of our skin, out of our lives, and then to also make sure that we're supporting our liver to help with the detoxification. And then making sure that our adrenals are, being supported, and thyroid health, thyroid is also being supported. And, I add here that supplements and herbs can still be a whole part of this picture. And, the doctors who just kind of give out hormones without addressing all of these, to me, I mean, if we do that, it's just as bad as the doctors that gives a patient a medication and doesn't look at all these things. So it's just as bad. Okay, one of the things I am in the process of doing is creating a course. It's called Women of a Certain Age. I'm very excited about it, and it is going to be an online course where we meet once a week. There will be a community, which I think is really important when we're trying to make some changes. And when we are in this time in our lives, I think community is super important. And hopefully that program will be out mid-January. You guys get priority to sign up for the program. So things to remember that I want to leave you with is it's your body, and it will tell you what it needs if you get quiet enough to listen. And again, HRT is not the end all be all. We have to have other things that we incorporate. And it's important to understand the different types of estrogens and progesterones and the effect they have on your body. And remember that not one size fits all ever. And, try to have patience on this journey into your best years. So patience with yourself, patience when you go on hormone replacement therapy, get a doctor who's patient with you. So number 4, find a practitioner who listens and supports you, and keep on learning and becoming your own health advocate. And if you need help with this, and I would say most people do, and most women definitely do during this journey, find a coach, find someone that can help you with this and to educate you. I'm one of those, but if you don't choose me, please find somebody who will help you, because it can be very daunting. All right, with some great resources here. So on the left-hand side, I've got 4 books listed here. The Great Menopause Myth is fairly new, and I'm enjoying this immensely. These 2 women are just wow, just really straightforward here. I like them. I like Avram Blooming's Estrogen Matters. I think he just came out. I think they just came out with the 2nd edition. And I highly recommend that for anyone, but I highly recommend it for any woman who is concerned about cancer and going on HRT. Any woman who has had cancer is concerned. Any woman who has a mother or siblings that have had cancer and they've been told by their doctors that they are not a hormone replacement candidate. Please read this book, okay? So you become more informed. Dr. Felice's book here, Menopause, 50 Things You Need to Know. Love this little book, little short book. She identifies how estrogen hits so many different tissues and organs and what it's actually doing when we don't have it. So it's kind of a fun reference here. Podcast, the only one I'm going to highlight here and talk about is Menopause and Cancer. And that is hosted by just a lovely woman, Danny Bennington. And I do feel that probably the most underserved group of women are the women who have had cancer. And they are just kind of left to their own devices, trying to get through the menopause maze. And I think it is a tragedy. Danny has her on her podcast. She invites many, many different practitioners, types of practitioners, ranging on a lot of different subjects and with different opinions, which I think is fine. And she also brings on people from the menopause and cancer community. So again, I think it's a wonderful place for a woman who has experienced cancer to be in, to learn, and to be supported. Instagram, there's a lot of people I like. There are some people that I think are a little over the top, and they're probably the most popular ones. I won't mention any names, but Dr. Men OBGYN, I really like her. It's Corinne Men. And she's also a cancer survivor, and she herself does take hormone replacement therapy. So I just like the way she reports and comes across. YouTube with Dr. Police Kirsch and Dr. Louise Newsom. There's other good people out there, but they're probably my favorite. And then you can always go to my website, and I've got a blog there, and I've got recipes and wellness posts as well. It's also a place if you would like to set up an appointment with me, an introductory call to find out more, to see if possibly I might be able to help you while you go down this path. You can book that there. There's an annoying pop-up that will come up. Okay, so I know a couple questions came in the Q&A, so I am going to try to answer them for you. So one was, I'm on a bias cream, and is that good? And what exactly is it? So a bias cream, I think, first of all, what it is, it's two different types of estrogens. It's estradiol, which is the estrogen that was circulating in our bodies the most when we're fertile, so it's produced in the ovaries. And then it also has estriol. That's usually the two different types, right, of estrogen that is used in the compounded cream. So estriol is the least potent and the least inflammatory of all the estrogen. And I think this came out of the combining the two, came out of, again, trying to be gentle and trying to make things safe after the Women's Health Initiative study. And most of what you're going to find in, patches and in gels and pellets and injections is straight estradiol. Okay, that's what you're going to find. So the compounding pharmacies have that ability to combine the two different estrogens. Now, I think it was really popular to do a 20-80, and what I mean is 80% of the weakest estriol, and then 20% of the estradiol. So it's a very weak form of hormone replacement therapy. And I know a lot of doctors have since then gone to the 50-50 estriol and estrogen, or an estradiol. I think it's starting to become a little bit of a dinosaur, a little bit. Although there are still some doctors, it's so interesting. There's a big war on whether or not you give a woman estriol along with the estradiol. There's 3 or 4 doctors that I feel are very, very smart, and how they're just in totally different camps. So, and it's up to you what you like. I did go from a 20-80. I was on that for years. And, when I started looking into estrogen and different types of replacement, I went, oh, I don't think I really want this. And so I'm on straight estradiol cream as we speak and enjoying it. Okay, another question is, this woman is on oral estrogen, and she wants to know how she can best support her liver. And I would say, with things like green tea and milk thistle and even taurine can all be really supportive of the liver. Eating vegetables, maybe even green juices can be really good as well. So just, supporting the liver as much as you possibly can. And someone said that I had mentioned thyroid as being an important part in perimenopause and wanted to know a little bit more about that. And she says that her doctor says that her thyroid is fine, but he's only tested, or she's only tested TSH and T3, So what should she ask for and how would she know? So the thing is with thyroid, especially in perimenopause, but it can also translate into menopause, is that if it is not working as efficiently and effectively as it should, it can mimic some and make worse some of the perimenopause symptoms. And when we have a drop in progesterone, by the way, it can affect the conversion of our inactive form of thyroid, which is T4 to T3. So that can affect the whole thing. So if you feel like maybe your thyroid is a problem, I would ask for a minimum of free T3. I would ask for the thyroid antibodies to also be tested and see if they'll do reverse T3. They may not. Here in California, it is really easy to order whatever you want, either online or through Quest and LabCorp. It's really easy to do that at cash prices. So I think that's it. So thank you so much for joining me. I hope this was helpful and take care.